What I'm going to do is just give you an outline of how we approach emergency evaluations for our athletic training students. Now, this does not mean this is how you have to do it with the students. We've all learned a different way, and one of the strengths of our clinical experiences is by giving our students so many variations of ways of doing things. So I'm just going to show you first of all where we teach this in the process, and then just a quick algorithm to show you how it comes out to them. So initially, emergency evaluations are taught in the second semester of their first year with us in a course that's numbered KPE 250. That's Prevention and Care of Sports Injuries. And again, it's just a kind of a quick layout of the algorithm we use. They don't spend a lot of time working on this in this course. It's more fine-tuned in the the first clinical course they take, which is KPE 201, and Paul Kalina teaches that one. So I'm just going to write down the algorithm that we have going on here. Some of this will look very, very familiar to you. Again, you don't have to hold them accountable to this. I just want you to see where they're coming from a classroom point of view. Obviously, we have a patient down, so the emergency evaluation begins, and that obviously begins with scene safety as well as their PPEs. And from there, as they're doing that, our patients are being assessed for consciousness or alertness. Now, they're given a couple of different methods of doing that, the AVPU method, but also the Glasgow Coma Scale. So they're familiar with both of those. Again, this isn't something that they spend a lot of time working on in KPE 250, but they are fine-tuning that in their first clinical rotation, and even more so in the rest of their clinical rotations. So please help them become more organized in their thoughts. So from these, we're going to have our patient either come out as alert, which we hope is the case, of course. But then if we're using the AVPU method or their lower GSC, we're going to see I'm just going to put VPU here so that you understand that they're only responsive to verbal or painful, or they're unresponsive altogether. And from here, we just begin the process of breaking it down. If the patient is alert, what are we going to do with them? And this is not in any specific order. As you know, when we're working with a patient, it could change at any time. So what I'm putting down here is what we teach the students, but knowing that you have to be ready to bounce should anything occur. They're familiar with conscious, oriented, and alert ×4. So you can incorporate that into their practice, if you will. They then go on to, or at some point, work on their S×3, which is assessing for spinal injuries, severe bleeding, and assessing for and managing shock. They'll take a brief history. If this is an emergent eval, we teach the brief history. A format of that they can be familiar with is the sample history. And of course, at any time throughout this, they can activate EMS, and they're told to do that as necessary. What we've tended to do with the alert patient is then move into more of a HOPS evaluation. So next would become probably observation palpations, recognizing that we teach our students to start the observation way back up here at scene safety. So I'll put down observation here, but understanding that that's going on throughout the eval. Palpations and special tests. Special tests here, we're looking more at more of a, circulation, movement, and sensations, maybe vitals, etc. From there, we would look at what is our our appropriate management, EMS, or move them to off field and then go from there. With the off field, we'd look at how are we going to take them off the field, perhaps splinting and transport would be part of the learning at that time. And so that's our alert patient. You can see it's pretty basic. And again, we're looking at our students just becoming familiar with being organized and becoming familiar with the actual skills themselves. We know that if a patient then, we'll go to this part, is having some alertness problems, we are probably activating EMS immediately or activating the EAP that you've already gone over with them. And then we go right into just basic life support. So CABs or ABCs, however you want to do that. Manage them as appropriate. Students in KPE 250 have to show proof of completing CPR AED training, so that will be part of their learning as they get into clinical skills KPE 201, 202, which are the students that you'll have initially. They'll have those. They may not be great at them yet, so that might be an area that you can suggest that they practice as well. And from CABs, any management, then we move on to the S times 3 as necessary, vitals, and handoff to EMS. Now, this is an area that we're beginning to get better at teaching our students. As we move into the master's level program, we want to make sure that our students are at a higher level, so we're incorporating a little bit more in-depth areas such as this, the handoff to EMS, and also their documentation. And what we're going to teach beginning this semester to the KPE 250 students is going to be using the eye chart method, and there will be a document if you're not familiar with that. I was suggested by a former student of ours, Dennis Russell, that our students should be participating in this type of documentation for emergency evals. So we will begin that this semester. And that, in a nutshell, is what we're looking at. The students, anything on here, the students have been taught how to do. You know, they have the skills for the vitals. They can do most of the vitals that you would be doing anyway: blood pressure, pulse, respirations. They know how to read the pulse oximeter. They know how to assess for skin and core temperatures, both the core temperature both as an oral and as a rectal. They know how to perform any of the basic nerve assessments with movement, sensation, and cranial nerves. They'll be able to perform Pearl observations and that type. So again, this is an emergency eval algorithm that we give to them early on in their academic career. And one of the things that we're finding is they don't really practice it in an organized format. So when the time comes, they get a little scattered. And we don't want them to be robots, but we also don't want them to be in a position where they're so nervous that they're forgetting things. So if you can incorporate this into any of your probably weekly sessions with the students and just say, hey, have you practiced an emergency eval yet? Or if you have an upper level student and you feel comfortable with them performing an emergency eval on a patient, that obviously is the whole purpose of having our students in their clinical experiences. So just hopefully this helps a little bit to give you an idea of what our students have been taught, not necessarily what they know at this point. Thank you.